Okay, switching gears. Slide 91, we're flying here. Extra heart sounds. So we have a pericardial friction rub. Let's talk about that. It's caused by inflammation and roughening of the pericardial sac, specifically between the parietal and visceral serous pericardium. We have a space, right, that's filled with serous fluid. That an inflammation can happen there. It can get rough like sandpaper, and then you got this sandpaper-like sound that is produced. One of the few murmurs that actually extends beyond one of the phases of the cardiac cycle. So it goes through S1, S2, into diastole. The other three are a venous hum, AV fistula, and a patent ductus arteriosus. Typically begins in systole and extends into part or all of diastole. So it's a really long sandpaper-like thing. And it sounds like a scratchy, it's high-pitched sounding. So is it bell or diaphragm? High pitches, diaphragm. And it will sometimes sound like sandpaper being rubbed together. And here's a sound. I won't click on it because it'll mess up my recording, but click on it and listen to it. They're best heard with the diaphragm at the apex or the left lower sternal border, so at the mitral or tricuspid valve region. And the patient should be seated in flexion. In that seated flexion expiration or position is good. Although it can really be heard anywhere in the pericardium, that's the best spot to hear it. Mayo Clinic says it's best heard over the left lower sternal border, that's tricuspid region, with the diaphragm in that same position. And Bates is silent on the subject. Etiology, it's often heard during the first week following a myocardial infarction, so it could be short-lived. It's not a good sign though. If a patient has a heart attack and you're treating him, he comes in, you listen to his heart and you hear this, it's a harbinger. Remember to know that word, harbinger. It's a bad omen. It's increased mortality rate. The 1-year mortality is quite a bit higher if this happens. And it may or may not occur in patients with pericarditis. So you don't have to have pericarditis to actually have this. Opening snap is another oscillatory sound. Almost always caused by mitral stenosis. That's underlined, so make sure you know that. Opening snap equals mitral stenosis. Rarely could be caused by tricuspid stenosis. When the mitral valve leaflets become sclerotic or calcified, they get stiff and sticky. They don't like to open during early diastole. So they kind of pop open when enough pressure builds up in the atria. Oh, yes, that's right. So mitral valve leaflets become sclerotic. Okay, yeah, that's right. In early diastole, they don't like they squeak open or they pop open. So when enough pressure builds up in the atria, they finally snap open like rusty gates opening, and they make the classic opening snap sound. They're best described as a high-pitched sound. So what are we going to use? The diaphragm. Let's see, heard with the diaphragm. And timing-wise or cadence-wise, they're located immediately following the S2 heart sound in early diastole, which makes sense. So we're in diastole. The atria hasn't contracted yet, so you don't need atrial contraction to open them. They'll open, but they'll make a little snap when they open. Likewise, it's best to auscultate this in the third or fourth intercostal space, so Erb's point, or down at the Erb's point is probably good, or fourth intercostal space, getting toward the tricuspid auscultation area. On EKG, it's located right after the T wave, and may be associated with or heard right before the low-pitched diastolic rumble murmur of mitral stenosis. We're going to talk about those murmurs in a little bit. Can be confused with a S3 sound or a split of S2. How do you know the difference? The opening snap has a greater interval of silence between it and P2. So S3 is low pitch, while the opening snap is a high pitch sound. That's how you can tell those apart. Here's what it sounds like. So take a break, go listen to this. And okay, here's a rhythm strip here. You can see S2 versus opening snap, early diastole. Another way to distinguish it from physiological splitting is to listen carefully during inspiration. You might actually hear what's called a triple sound. So with an opening snap or with inspiration, with physiological splitting, you'll get a lup da da lup da da lup da da during inspiration, lup da da. But if there's an opening snap in there, you'll get a lup da 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 lup da 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 lup da da da. So they'll probably blend into one sound, but okay, let's move on. Something new, ejection clicks. Oh, look at the AKAs for this. No one can agree what the heck the ejection click is. A systolic ejection sound, a systolic ejection click, ejection sound, which I like, ejection sound, ejection click I think is fine. Pulmonic ejection sound, aortic ejection sound, early systolic sound. A lot of texts still use that. Lilly actually uses an early ejection sound, but Mayo and a lot of other books, ejection clicks. Should have underlined early ejection sound. Pulmonary ejection click, aortic ejection click, pulmonary click, aortic click. So ejection click, pulmonary click, aortic click. Keep it simple. Results from a noisy opening of a stenotic semilunar valve. Could be aortic, could be pulmonic. It's just a noisy little guy. Closely follows then the S1 sound. So can be confused with a widely split S1. Pulmonary click is best heard over the pulmonic area or the left upper sternal border. A lot of these cardiology books don't use the pulmonic auscultation area. In fact, hardly any of them do. They always just say for pulmonic area, they would say the left upper sternal border. It's an AKA. Or the tricuspid valve would be the left lower sternal border. Or the aortic area would be the right upper sternal border. If a pulmonary valve, if it is a pulmonary valve problem, then it will often disappear with inspiration, which is very rare. Aortic click is best heard in the aortic area or in the mitral area. If it is an aortic valve problem, it does not change with respiration. Causes of ejection clicks. So we can have aortic clicks. So that's something, the aortic valve is stenosis. It's stenotic and not it's opening with a noise. Presence of a bicuspid, we're not going to have time to get to this, but sometimes you can have a lot of trouble. In fact, the aortic valve is supposed to be tricuspid, right? Some people, it's bicuspid, and that's the number one cause of surgery on a bicuspid aortic stenotic valve. You could have an aortic root dilation could cause this click. So if you hear aortic click, think aortic valve stenosis, maybe a bicuspid aortic valve, aortic root dilation, or even an aneurysm. Now if you hear a pulmonic click, think pulmonary valve stenosis, atrial septal defect, chronic pulmonary hypertension, tetralogy of Fallot, idiopathic dilation of the pulmonary artery, which only anatomists really say the pulmonary trunk. Everybody, cardiologists, everybody uses pulmonary artery, so that's AKA. The etiology, of course, is not completely understood, but there's three possible mechanisms. one theory is Cleveland Clinic, there's some intrinsic abnormality of the aortic or pulmonic valves. And it's especially like some developmental defect or structural defect, like a bicuspid aortic valve. A dilated pulmonary trunk can do it, or a dilated ascending aorta. Lilly and Cleveland Clinic both agree on that possible cause. Increased pressure in the great vessel from pulmonary or aortic hypertension. So if you have too much pressure in the great vessels, can also cause this ejection click. The discovery of an ejection click, no matter what valve is involved, is always considered pathological. So it's not a good thing to hear. Now we have mid or late systolic clicks, a bunch of AKAs. Cleveland Clinic calls them non-ejection clicks. There's mid to late extra systolic sounds, mid to late non-ejection clicks, systolic clicks. Still occurs in systole, but it's now just later in the cycle. The ejection click happens in systole, but it's earlier in the cycle. Most commonly associated with mitral valve prolapse. It's underlined, that's important. So think mid or late systolic click, think mitral valve prolapse. The prolapsed cusps quickly stretch out the chordae tendinate, stretch them too tight, which causes the clicking noise. Often accompanied by a regurgitation, mitral valve is degenerated with myxoedema. We don't need to know that. More rarely associated with tricuspid valve prolapse. So these mid or late systolic clicks are associated with mitral valve prolapse, rarely tricuspid valve prolapse. Auscultation sounds are described as short, click-like, and high pitch. Therefore, best heard with the diaphragm over the mitral area. If the tricuspid valve, then it's heard over the tricuspid auscultation area. These non-ejection clicks are dynamic. What does that mean? That means you can use some maneuvers to help make the diagnosis. For example, with Valsalva's maneuver or other maneuvers that decrease left ventricular volume, like standing up quickly, the heart size decreases. You squeeze all the blood out of it, and then the click it'll move closer to the S1 sound, or you could say it moves the click to an earlier location in the cycle. Okay, and the click may even disappear because it could become superimposed upon S1. So if you can use the Valsalva's maneuver and make the click disappear, you probably have a mid or late systolic click. Maneuvers which increase left ventricular volume, like a patient supine and raise both leg lengths, or maybe a little bit, have the patient take a deep breath, super deep breath, will suck some blood in there. This moves the click later in the cardiac cycle, closer to the S2 sound. A big error in Jarvis says Valsalva's maneuver moves it closer to the S2, but this is definitely not true. They need to fix that in Jarvis. And here's the sources against that. Lippincott. All these, everybody confirms what I just said. No one says this. That's a mistake in Jarvis. Okay. We're on the last section now. Go get some coffee, come back. This is kind of a tough section. Cardiac murmurs. So heart murmurs, cardiac murmurs. A heart sound caused by turbulent blood flow. Simple so far. Under normal conditions, the movement of blood through the heart is laminar, smooth, everything's great. Not with heart murmurs most times. Secondary to this, heart murmurs are in general secondary to hemodynamic or structural changes that mess up laminar flow to the point it creates an audible sound. Causes of murmurs: you could have a flow across some type of obstruction like aortic stenosis or pulmonary stenosis, or any stenosis of the valve. You could increase flow through the normal structures. If it increases flow, if the blood viscosity decreases or speeds up, the high output states, the thyrotoxicosis, anemia, wet beriberi, AV fistula, fever, pregnancy, exercise anxiety, these will all could cause a murmur, or it could accentuate a budding murmur or murmur that you can't hear very well. Flow through a dilated chamber, like if the chamber, the atria ventricle is too dilated, you can get a murmur. Regurgitation across the incompetent valve, a valve that blows open and doesn't seal. That's a regurgitation type murmur, like mitral regurgitation. Or a flow through an abnormal shunt can make a murmur, like a VSD or ASD. Description: systolic murmurs are murmurs described by the following characteristics. So when you describe a murmur in a report, these are some of the things you need to talk about. A timing: is it a systolic murmur? The majority of murmurs are systolic. There's a few diastolic murmurs. I think there's 3 of them we'll talk about. Continuous: the timing, does it spread from S1? Does it spread from systole into diastole? So the timing. The intensity: there's a grading system. I'm not going to hold you responsible, but you should know it's a 6-point scale. So grade 6 is the murmur is so severe you don't even need a stethoscope to hear it. So that's crazy. From barely audible, medical, chiropractic, physical therapy, acupuncture student will miss it. More descriptive terms is the pitch. Is it a high frequency murmur? Or is it a low frequency murmur? Shape. This is important. How does the murmur change with intensity over its duration? Is it a crescendo murmur? Does it build up and get louder and louder? Or is it a crescendo decrescendo murmur, which is red because there are a lot of them are crescendo decrescendo? If you're a musician, you know exactly what I'm talking about. The sound, the intensity will get louder and louder, and midway through, or at some point in the murmur, it'll start to get softer until you can't hear it. That's a crescendo decrescendo murmur. Decrescendo murmur, it starts off loud and it trails off. Location, of course, you need to describe what auscultation area you hear it. Radiations, I'm not going to get into this, but it's actually pretty important where these things radiate to. So you'll hear a murmur, let's say you hear one over the aortic auscultation area, but it may radiate to the axilla, mid-axillary line. These get really complicated. I really could spend probably a whole week talking about this subject, so we're not going to worry too much about that. And then how do they respond to maneuvers? Valsalvas, the squatting maneuver, or fast standing up, double straight leg remove, clenching fists. How do they respond to these maneuvers can help you make the diagnosis of a murmur. And of course, in our practice, we just need to know what a normal heart sounds like, and if we could maybe pin down a simple murmur, great. But we're going to refer out any sound that's not normal. But this is for board purposes. This stuff is on boards. And if you're, as I say in lab all the time, if you're out in the sticks, what if you're in Alaska and there's no primary doc around, or a medical doc around? This stuff could come in handy. You will be expected to know this stuff. That's why we get trained in it, because we are primary care health providers. So we need to know this stuff just like a general family doc does. Systolic murmurs, they can be subdivided into 3 types. There's a little argument about this as well. Lilly puts them into ejection murmurs, aka is mid-systolic murmur or systolic ejection murmur. So ejection murmurs are fine, I think. Then we have a pansystolic murmur. A strong aka is holosystolic murmur or regurgitant murmur. These are all, notice they're all red because these are all used interchangeably. Probably the best one is holosystolic murmur. But regurgitant, we could keep it simple too. Ejection murmurs is one, regurgitation murmurs is another, and then there's a late systolic murmur. So this was a this is a modified version of Perloff, who has a classification system. So Lilly actually left out the early systolic murmurs, or he left out the late systolic murmurs, or was it the early systolic murmurs? Anyway, this is what we're going with right here. All right, this is the Perloff classification. This is the gold standard. It's like we're going to learn the Linke system when you get in 8th quarter, not the older systems. Anyway, so here's a mid-systolic or an ejection murmur, and you can see it's a crescendo decrescendo, and you're going to hear this between the lub and the dub. So lub squish dub, lub squish dub, lub squish dub. A holosystolic murmur, that's why the holo is a better word, because it's, now there's several categories of this, but the worst one, the most common, is just a whoosh. You won't even hear S1 and S2. It's a whoosh, whoosh. And so it's pretty easy to recognize. Early systolic murmur is a decrescendo, just lub dub, lub dub, lub dub. And a late systolic murmur is sometimes you have a click in there, lub click stub, lub click stub. Of course, I'm going to give you a whole bunch of links to go listen to these things. More classification systems. Okay, here's a little rant here. Like Mayo Clinic used the simple system, which maybe we should have used. The simple system from 1958, this Letham system, which just had basically ejection type murmurs or regurgitation type murmurs. Some of the board books go a little deeper though. Ejection murmur. So this is aka mid-systolic murmur, and this is the lub stub, lub stub, lub stub. And so memorize ejection murmur, and it's associated with semilunar stenosis, either aortic or pulmonic semilunar stenosis. It begins, as we can see, it begins right after S1 and finishes just before S2, or specifically, if you're during respiration, if you hear a normal split, it finishes before A2. So notice there is a definite delay here, and that delay differentiates this murmur from a holosystolic murmur. The shape is, we said, crescendo decrescendo. Could have a click before it. The cartoon, I think I just said all this stuff. Aortic stenosis. Let me see something real quick here. Okay, aortic stenosis, so we're splitting these, presents as a high frequency ejection murmur. So that kind of follows in the normal trend. We don't use the bell up there, we use the diaphragm. Best heard in the aortic area, although it typically can be heard throughout the pericardium. And the murmur typically radiates to the neck. Maybe this is one we should actually know, because remember, aortic stenosis, that can be as severe as getting cancer. That's a really bad one. So let's know this. The murmur can radiate toward the neck. Here's some really good sounds of it, so check out those sounds. So next, a pulmonic, this is the same subcategory. Pulmonic stenotic murmur differs slightly. It's often preceded by an ejection, it's also preceded by an ejection click, high frequency. But here's the difference. Unlike the aortic stenosis, pulmonary stenotic murmur may extend beyond A2 and terminate at the end of A2. In other words, it terminates with S2. Typically heard best at the pulmonic auscultation site, which is simple, and it does not radiate like the murmur of aortic stenosis, because it's not under as much high pressure. But when it does radiate, it goes to the neck or left shoulder. But for us, it doesn't radiate. That's how we can tell them apart. Let's take a picture of it. So crescendo, decrescendo. This one actually goes through A2. And I mean, it's hard enough to hear these as it is, right? A2 and this split. And this is during full inspiration, right? But the bottom line is there's going to be a delay. It's not going to start like a holosystolic murmur. It's not going to start right at S1. It'll be lub, sh, lub, sh. You won't really hear dub that well because it's masking it. What does this murmur pattern tell you? That's kind of an in-between murmur, isn't it? So that probably means the stenosis is not as bad. With increasing severity of semilunar stenosis, the murmur gets louder and louder and louder. So that cartoon, what does that say? I think previous cartoon, that's supposed to be. Previous cartoon depicts a moderate, so kind of a mild, moderate ejection murmur secondary to moderate semilunar stenosis. So when it's severe, it can go all the way to S2. Okay, next category, pansystolic murmurs. Better word is holosystolic. Another word is regurgitant murmurs. So it's caused by regurgitation of blood through the mitral valve, tricuspid valve, through a ventricular septal defect. Okay, so the murmur produces usually holosystolic, which means it starts immediately at S1 and continues all the way through S2 without intensity change. We looked at this already. Here's a nice picture. So it's just shh, 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 and go listen to the real sounds. It doesn't always have to be like that, but typically the holosystolic murmur, that's the holosystolic murmur of mitral regurgitation. That's the typical one you'll see. Less severe ones won't go all the way. They won't be pansystolic. They won't go pan or holosystolic means it's all the way from S1 to S2. But occasionally you can still have this type of murmur, which would be then just called a regurgitant murmur. Unlike other systolic murmurs, there is no delay. Here's how you tell it apart. There's no delay between the start of this murmur and S1. It's a high-pitched murmur. It's best heard with the apex for mitral regurgitation. So some other mitral murmurs are low-pitched. This is a high-pitched murmur. All right, so let's see. So if it's tricuspid valve could be regurgitating as well. So that would be heard at the left lower sternal border or the tricuspid auscultation area. All types have classically bored, I should underline, a blowing quality about them. Mitral regurgitation murmurs may radiate to the armpit, but does not change. I guess we better know these because you're going to have trouble. These radiations, I guess, are important for murmurs. So I take that back. We can just add this in there. It's not that bad. Mitral regurgitation radiates to the armpit, and it does not change it doesn't split with respiration. Tricuspid may radiate to the right sternum, which makes sense on the right side. Not much goes to the right side, and may increase in intensity with inspiration. How would that be? Well, inspiration increases the amount of blood in the right atrium and ventricle. So more blood is being regurgitated, right? Inspiration sucks blood in. So that's why it's increased in intensity. A ventricular septal defect can also cause this. In fact, in little kids, this is a common cause of it. It's also high-pitched. VSD best heard at the left lower sternal border. The smaller the VSD, the greater the turbulence and the louder the murmur. Okay, that makes sense, like putting your finger over a hose. So these are also the only ones typically associated with a palpable thrill, underlined. Right? We talked about that in lab. Sometimes you can actually feel turbulent blood flow with the metacarpal phalangeal joints, and this is one of them. So a pansystolic murmur associated with a ventricular septal defect is palpable. The intensity of the murmur does not change with inspiration. Okay, these murmurs do not radiate anywhere, so that's the way to should underline that. These murmurs don't radiate, which helps distinguish it from a mitral or tricuspid regurgitation. Minor pansystolic murmurs. So when the regurgitation or the VSD is minor in nature, you may get a small decrescendo murmur, which starts at the beginning of S1 and fades out. So you might actually, so these can get confusing, right? But these are more rare. I didn't put anything in red here, so let's not worry about them. And technically, I don't think these should be called regurgitation murmurs, because pansystolic or whole systolic means they go from S1 to S2. Okay, benign systolic ejection murmurs. So these are innocent murmurs. So these are quite common in children. Now we had to get out none of the books, the 5 books really were the greatest on these. So I actually went to a really good, expensive book called Park, 2014. He did a very good job, footnoted, and great book. So innocent murmurs, and this matches with the board books too, but it just explained it a little bit better. So innocent murmurs are very common in children. 80% of children have these innocent murmurs at some point in their childhood. Most common innocent murmur is called Still's murmur. A Still's murmur, or AKA a classic vibratory murmur, AKA vibratory murmur, is I should have read that. But Still's murmur, it's most common. You need to know this one. So it's the most common, again, innocent murmur in children. Typically arises between the ages of 3 and 6, but it can be all the way from infants to adolescents. And it's a faint, it's only a 2, sometimes a 3 out of 6. It's a mid-systolic murmur. It's best heard at Erb's point. There's Park. There's the full 6th edition, Pediatric Cardiology for Practitioners. Excellent book if you're into this stuff. Classically described as a twanging of a string or a groaning, squeezing, buzzing, vibratory sound, which gives it almost a musical note-like quality. It's generally low in frequency, so it's heard with the bell. The patient's going to be supine. What causes the murmur, of course, is still debatable. It's thought to be generated by low frequency vibrations of normal pulmonary leaflets. There's a nice recording actually on Wiki of a Still's murmur, so you can go check that out. But benign systolic ejection murmurs. So continuing with this theme, in older people, they generally can get these as well, secondary to a sclerotic or aortic valve. Interestingly, that Parks didn't even mention this. The only reason I'm putting this in here is in Jarvis, so I'm not sure, but I just want to make sure it doesn't pop up on boards. But I would have left the slide out if Jarvis was in our book. In older people, though, they can get these secondary to sclerotic aortic valves or dilated aortic root, best heard at the aortic area, left sternal border. I shouldn't have read this slide. I'm not going to worry about this. Typical causes are typically caused by, so again, these systolic murmurs. This is Mayo Clinic and Lilly. So they have some ideas about what causes it as well, by an increase of systolic flow across normal semilunar valves. I think we just said that. I think that's what Park said as well. Often becomes soft or disappears when the patient sits up. Usually present as a soft, okay, grade 2, that's matching Park, and it's quite short. So it's never a pan or holosystolic murmur that goes from S1 to it's short. And the key is on these things, if you hear a murmur in a child, or they can be in an older too, but usually a child, they don't have any abnormal clinical findings. They don't have any dyspnea. Everything is fine with them. All right, the last, we're almost done. Last category here is late systolic murmurs. These begin in late or mid to late systole and end at S2. In fact, I think the other books just clump these in with mid. They did. They call them mid to late systolic murmurs. But the real classification systems classify these by themselves. So most common example is mitral valve regurgitation. In all the board books, everybody agrees on this. These late systolic murmurs are because of mitral valve prolapse. So it's a regurgitant type murmur. It's typically preceded by a mid-systolic non-ejection click. So it's a lub clip stub, lub click stub, lub click stub. All right, done with those. Diastolic murmurs. Let's hit these now. Diastolic, there's Parks again, or Park 2014 6th edition. These are best classified into three types. There's early diastolic decrescendo murmurs. There's an AK I don't care about. Mid-diastolic murmurs and late diastolic murmurs. And now we're in diastole, right? We're done with systole. Systolic murmurs are by far the most common, so there's not many diastolic. Early diastolic decrescendo murmurs. So heard obviously in diastole. Immediately after S2, which makes sense. So early diastole start caused by what? An incompetent semilunar valve. Incompetent, so it's a gushing, it's a leaking semilunar valve. And it's typically the aortic valve that's the culprit because it's under higher pressure. So aortic regurgitation murmurs can cause early diastolic decrescendo murmurs. Aortic regurgitation murmurs are high-pitched, best heard at Erb's point. Left sternal border, third intercostal space, for those of you who forgot. Significant aortic regurgitation will also cause a bounding pulse in the periphery. Picture's always best. Pulmonic regurgitant murmur also occurs in early diastoles, decrescendo as well. They are usually medium pitch unless the patient has pulmonary hypertension. Then they're high pitch just like the other ones. Pulmonary regurgitation is best heard at Erb's point, which is a little strange. You would think it would be heard at the pulmonic valve, but it's not. So both of these, pulmonic and aortic, are heard best at Erb's point. And here's what it looks like. So it's a lub dub gush, lub dub gush, lub dub gush. So mid-diastolic murmur, they start with a loud S3 and are heard in early or mid-diastole. Loud S3, so they're associated with an S3 sound. Was that Kentucky or Tennessee? Let's see. I know there's a S3 and I know there's a S4. I know there's a Tennessee. I know there's a Kentucky. Kentucky comes first, matches with S3. Tennessee matches with S4, so it's Tennessee. Bop, bop, bop. Freak, I'm screwed. Freak, I'm screwed. S3. So this one gangs up with a S3 sound caused by turbulent blood flow secondary to anatomical stenosis or relative stenosis. What the heck? Relative stenosis. Well, if you have a VSD or ASD, it can form a situation where you have, it's just like a stenotic valve. That's called a relative stenosis. The valve isn't actually stenotic, but because of shunts within the heart, it creates a stenotic-like situation. So mitral mid-diastolic murmurs are also low pitch. That makes sense. Best heard with the bell at the apex of the heart. Classically described as here's a board thing, apical rumble. Apical rumble. But in reality, they sound more like a humming noise. Tricuspid mid-diastolic murmurs are best heard along the left lower sternal border, tricuspid area. That makes sense. Also associated with atrial septal defects, anomalous pulmonary venous return, like the pulmonary veins are up at the right side of the heart or connect at the right side of the heart. So they result in a relative tricuspid stenosis. So nothing wrong with the valve, but because of these shunts, abnormal shunts, it acts just like stenosis. Rarely the tricuspid valve is stenotic in itself. Okay, late diastolic murmurs, aka pre-systolic murmurs, comes right before systole. Also caused by a flow through AV valves during ventricular systole. Results from the, well, what's late diastolic, late systolic or late atrial diastole or late ventricular diastole is the same as atrial systole. So it results from atrial contraction, I should have read that, that injects blood into the ventricle. It occurs late in diastole, of course, and these are low frequency murmurs as well. Occurs secondary to, what does it occur from? Secondary to anatomical stenosis, real stenosis of the mitral or tricuspid valve. A couple more and we're done. Continuous murmur. So it begins at S1, so it's just a, instead of a lub-dub, it's just a just a whoosh, whoosh. You don't really even hear the lub-dubs very well. Begins at S1, continues throughout systole, spills over into diastole. It doesn't always have to spill all the way, right? This is diastole right here, right? Systole, diastole. So it doesn't always have to spill all the way over, but on the test it will. Caused by the by these phenomena, so it could be a patent ductus arteriosus. Patent ductus arteriosus, classic board, I should have read that. It's always a machine. I remember this from school. Way back in the day, the murmur has a machine-like quality. So go listen to this to hear what I mean. So a PDA can do it. A AV fistula can do it. A disturbance of flow patterns in the veins can do it. You can get a venous hum. Disturbance in flow patterns in the arteries with a coarctation or a pulmonary artery stenosis itself, or pulmonary trunk stenosis can cause this as well. Now here's another one. This is the second time we used a thrill, continuous murmurs. So a thrill is often palpable in the left upper sternal border. That's Jarvis, so I didn't see that with any other of the books, but I throw it in there. Best heard in the left, under the left clavicle, which is a weird spot for this murmur, and is accompanied by a wide pulse pressure. Cleveland Clinic, which is a really good book. Cleveland Clinic, Mayo Clinic, they're both really good, although Mayo Clinic isn't as good as the Cleveland Clinic book. These patients are often symptomatic, and they have these symptoms: exertional dyspnea, cyanosis signs, and clubbing. Talked about clubbing a little bit in lab. So that's the first time I've used clubbing. So clubbing, continuous murmur, C, they both match. Clubbing, continuous murmur, easy to remember. All right, thank you for listening to this. It's too bad I couldn't do this in the real class, but at least you'll be able to play this lecture over and over, because it is a hard lecture. 150 slides, 149 slides, and you'll take your time through this, but this will be heavily hit on the final because this is important stuff. Okay, see you in class.